Hi there, my name is Will Niven. I'm a consultant in emergency medicine at the Homerton University Hospital, and I'd like to talk to you today about how to critically appraise a diagnostic test study. The objectives of this brief talk are to give you the tools to appraise a diagnostic paper, particularly with respect to the main questions you might need to ask, how to interpret the basic stats involved in diagnostic studies, and then finally to help you decide if this paper is relevant to your practice. Now, what we'd like to see is, in the introduction or background, a topic introduced nice and early. It should provide some of the context of the previous research, in other words, the seminal papers that have already been published, a rationalization for the research, in other words, what question is not yet answered, and that should be summarized in the aim. The methods or methodology section really looks at the how aspect of the study. In other words, how was the study conducted? How was the sample size calculated? How were patients recruited? And how were they followed up for the outcome of interest? You really want to know if the study is practical and potentially repeatable according to the explanation given in the section. And this will to some extent be answered by whether or not there's a PICOT style type question that's actually addressed. So just to summarize again, a PICOT stands for Population Intervention Control Outcome and the Time Frame. Population could be might be an example of a cohort of patients over the age of 21 who presented with chest pain of suspected ischemic origin. The intervention in the context of diagnostic papers is often the new test under question, for example, heart fatty acid binding protein or HFAB. The control is usually the gold standard test, for example, troponin I or troponin T. The authors should clearly state what the outcome of interest is, such as myocardial infarction, revascularization, or death at 30 days, otherwise known as MACE. And then a time frame should be given for the study as well as for the outcome of interest. So it could be 30-day MACE, 6-week MACE, or 4-month MACE. The methodology section should include the setting, for example, a busy inner-city district general hospital. The authors should mention how the sample size was calculated and what the inclusion and exclusion criteria were, how the recruitment took place, for example, 7 a.m. to 7 p.m. weekdays over a period of 4 months. And then you should really find out whether the patients recruited are representative of the population of interest. For example, if you're conducting a study on patients who present with chest pain to the emergency department, but actually only include those patients who walk through the front door, then you might be missing out on patients who have arrived by ambulance, potentially skewing your data in favor of less acute patients. The gold standard is the best available test under reasonable conditions. So, for example, the gold standard test for the diagnosis of a type 1 myocardial infarction is coronary angiography that identifies intracoronary thrombus. So that's a single accurate test. But practically speaking, it doesn't always make sense to carry out an angiogram on every patient. So we've evolved a definition that basically combines troponin and a mix of other objective and subjective criteria as a surrogate for the diagnosis, otherwise now known as the third universal definition. Sometimes the reference standard used will not be the gold standard because the test is too tricky to do, for example, venography for DVT. So we've actually got to have a good think and develop a reference standard that's almost as good as venography, for example, Doppler ultrasound. The problem is that there will always be some false negatives when you're not using the gold standard, i.e. people who have the disease in question but happen to have a negative test, and we need to find some way of identifying them. This is the reason we often rescan in the case of individuals with a high Wells score and a positive D-dimer. In the case of diagnostic studies, there are really two kinds of bias you need to watch out for. The first is known as workup or verification bias. An example would be patients who present with wrist swelling being more likely to get an X-ray than those who do not. If you did a study in which only those with wrist swelling got a gold standard X-ray, then you could potentially be missing those patients with no swelling who still had a fracture. This will lead you to overestimate the sensitivity of X-ray because you've only included those patients who are likely to have a fracture. In other words, you get more true positives. And conversely, you will underestimate the specificity because you are no longer X-raying those patients who are not likely to have a fracture, and you have fewer true negatives. The other form of bias is incorporation bias, when the diagnostic test under evaluation forms part of the reference standard. Troponin is used to both diagnose myocardial infarction, but it also forms part of the reference standard. This means that you are more likely to diagnose those with an elevated troponin as having an MI, even though we know that troponin can be incidentally raised as a result of myocardial strain without any infarction per se. Blinding is all about ensuring that the person measuring or interpreting the diagnostic test under evaluation is blind to the result of the reference standard. If the person already knows the result of the reference standard, then they would be more likely to lack impartiality when interpreting the results of the test of interest. So if we wanted to know whether the ECG was a reliable indicator of MI, then we could not have the person reading the ECG knowing what the result of the reference angiogram was, because they will interpret the ECG in the light of that crucial information. The next concept that I'd like to talk to you about is inter-observer error, which is a very important part of diagnostic tests and gives us some information on how reproducible the test is when measured by different clinicians. The more people that agree on a test, the more reliable it is. When you have an objective measurement like serum troponin that is numerical and has clear cutoff values, then there's usually perfect agreement. But if you have something that relies on interpretation, for example whether there's a clot in the deep venous system on Doppler ultrasound, then this is obviously vulnerable to subjective variables like operators' technical skill and experience. Agreement or reliability is classically measured using kappa or weighted kappa scoring, where 1 shows perfect agreement and 0 shows no agreement whatsoever. The following are the important terms in diagnostic papers, and you need to concentrate a bit because it's the most technical part of this talk. Sensitivity and specificity tell us about who has or who has not got the disease, and positive and negative predictive value tell us more about who has a positive or negative test. Let me now elaborate. Sensitivity is a statistics that tells us what proportion of patients with the disease has a positive test. If sensitivity was, for example, 85%, then we would know that 15% of the patients with the disease will have a negative test, which really wouldn't be good enough for us. Let's take the example of troponin, which we know will always rise in the context of myocardial infarction. Because of this, patients who do not have an elevated troponin do not have a myocardial infarction. So troponin is a sensitive test that helps us to rule out myocardial infarction. Sensitivity is the proportion of patients with a positive test. So we divide all those who have the disease with a positive test, as given by A, by the total number of people who actually have the disease. That's A plus C. So what's specificity? Well, this is the proportion of patients without the disease who have a negative test. So a specific test will be good for ruling a disease in because there's a low proportion of false positives and a high proportion of true negatives. Numerically speaking, specificity is measured by dividing all the true negatives, so those who do not have the disease and have a negative test, otherwise designated by D, by all the true negatives, D, plus the false positives, B, those who had the positive test but don't actually have the disease. Thus, if you performed a CTPA on 100 patients who did not have a PE, and 2 of the tests were positive and 98 were negative, then you could say that the CTPA has a specificity of 98%. Positive predictive value is the proportion of patients with a positive test who truly have the disease. And unlike sensitivity and specificity, it alters with the prevalence of disease. In this 2x2 table, you can see that the PPV can be worked out by dividing all those who have the disease in a positive test, true positives, designated by A, by all those who have a positive test, true positives and false positives, or A plus B. In order to show you how the PPV changes, let's take the theoretical example of 1,000 patients in which the test is 90% sensitive and 90% specific. Now watch in the next slide how, if we substitute values for a 5% prevalence and then for a 10% prevalence, the positive predictive value will change. So, really slowly now. If I have 1,000 individuals and a test that is 90% sensitive and 90% specific, I've shown in the example on the left what will happen to the positive predictive value. There are 45 people who have the disease and a positive test, true positives, and 95 people who do not have the disease but still have a positive test. We then divide the 45 true positives by all the people who have a positive test, and we get 0.32, which when multiplied by 100 gives us a positive predictive value of 32%. On the right, I've done the calculation only with a prevalence of 10%, and what you can see here is that the higher the prevalence, the higher the positive predictive value. Negative predictive value is quite simply the proportion of patients with a negative test who truly do not have the disease, and just like the positive predictive value, the negative predictive value will alter with the prevalence of the disease. In this case, the less prevalent the disease, the higher the negative predictive value, in contrast to the PPV. From a mathematical point of view, we calculate the negative predictive value by dividing the number of true negatives, D, by the total number of people with negative tests, C and D. To use a simple illustration of how the negative predictive value is put to use in clinical practice, let's take the case of the Wells score and D-dimer. The low-risk group will have a lower prevalence of DVT and VTE, and if we combine it with the D-dimer, we then have a tool that has an excellent negative predictive value for DVT. So to summarize, the more sensitive your test is, the better it is at ruling the disease out. The more specific your test is, the better it is at ruling the disease in. Sensitivity and specificity remain the same no matter what the prevalence is, and as regards the positive predictive value, the higher the prevalence, the higher the positive predictive value, and in contrast, the negative predictive value, the lower your prevalence is, the better your negative predictive value becomes. So now you've worked out the sensitivity, specificity, positive and negative predictive values, it's important that you add up the numbers in each of the four cells above to confirm that it equals the total number of participants the authors say were enrolled. You never know what jiggery-pokery you may find. Likelihood ratios. This basically tells you how diagnostically useful a piece of information is. It's a number between 0 and infinity, and if it's greater than 1, it indicates that the information increases the likelihood of the suspected diagnosis, and if it's less than 1, it indicates that the information decreases the likelihood of the suspected of the diagnosis in question. As you can see over here, from 0.5 to 2, a likelihood ratio basically doesn't show anything significant. If it's less than 0.2, it really markedly decreases the likelihood of your patient actually having that disease, so it could rule the disease out. And if it's more than 5, it markedly increases the likelihood, and it could actually end up being diagnostic. Here is a summary of the mathematics involved in calculating the likelihood ratio of the positive and negative tests. ROC curves are important to understand if we're to understand the value of tests in clinical practice. In this diagram, the blue bell curve represents a standard distribution of values for a particular test in a well population, represented on the x-axis. The red bell-shaped curve represents the standard distribution of values for a test for individuals who have the disease in question. The area of overlap represented by purple in the middle, represents the point at which the test is inaccurate. And if we were to draw a line parallel to the y-axis to signify the test cutoff value, we can see that the purple area to the left represents the false negatives, and the area to the right of this line represents the false positives. If we move that line to the left, we'd have a really sensitive test that picked up everyone with the disease, but then we'd increase the number of false positives. Alternatively, if we move that line to the right, we'd then have a really specific test, but we'd get a lot of false negatives and miss some of the people who had the disease. We take the cutoff values for the test in question, and then we plot their sensitivity and 1- specificity on a graph and join up the dots, and that represents a ROC curve. In the example of the graph on the right, if we took a T4 level of 9 micrograms per deciliter as being the level below which we diagnosed hypothyroidism, then we'd pick up nearly everyone with hypothyroidism, but because the level, whilst low, could be normal in euthyroid patients, we'd have a lot of false positives. If we took a cutoff value of 5, then we'd pick up everyone with hypothyroidism, but miss some people who actually had the disease or the false negatives. So from this curve, we can see that 7 is the Goldilocks point where you have the best trade-off between sensitivity and specificity. So the closer the test is to the left and upper borders, the more accurate your test. The closer the test is to the 45-degree linear line, the less value it has. The slope of the tangent line at the cutoff point gives the likelihood ratio discussed in the earlier slides. So you can wipe your sweaty brows because the stats are over. The next question is really whether or not the study is valid. And there are really two types of validity that we're concerned with. One is the internal validity, in other words, how well was the study conducted, and you'd need to appraise the introduction, the methods, the results, analysis and further discussion in order to decide whether the study is actually valid in that particular context. And then we'd look at the external validity, which is the extent to which the results of this particular study can be extrapolated to a number of different contexts and different populations, in other words, the generalizability. And finally, you need to ask the question of whether this is actually going to change your practice. Is this an important study that's actually going to change the way we do things? Is it applicable to the population that I work with and to the setting in which I operate? And finally, the 4 Bs of implementation. Are there any barriers to change? What are the beliefs of the clinicians that might need to adopt the change? Is this test now actually going to speak to a disease that's actually relatively common, or is this a test that we're not going to use a hell of a lot? In other words, the burden of disease. And is this going to be an expensive change because budgets always feature? So in summary, the first question is whether or not this diagnostic paper is relevant to your study. Is there a gold standard to which the new test is being compared? Were the people measuring the outcomes blinded? What was the inter-observer reliability? We've gone through some of the stats, particularly associated with the 2x2 tables, moved on to likelihood ratios, conclusions, and then finally whether or not this is actually going to make any change to your practice. So I hope that's been useful today. Please read the paper that I've now distributed to all of you, and I look forward to seeing you on the 10th of January. Take care.